Hello and welcome to Psyched, the show where we explore psychedelics through social, economic, and political perspectives. Introduce our next speaker. Next up, we have Dr. Mark Braunstein. Dr. Mark Braunstein is a psychiatrist who uses modalities such as wilderness therapy, osteopathic medicine, and cannabis psychiatry to help patients. He's the medical director at Medicinal Mindfulness, the Chief Psychedelic Officer at Ehave, and recently became the Chief Medical Officer at the Phoenix Psychedelic Healing Center. Dr. Mark Braunstein, welcome to Psyched.
Good morning. Happy to be here today. Give me 1 second just to get my screen sharing set up, please. So yeah, good morning. I'm Dr. Mark Braunstein. I'm from Durango, Colorado, and I'm here to talk about ketamine today. This is going to be like a general overview of ketamine, kind of an introductory Ketamine 101 lecture. And just would like to start by introducing myself. I'm Dr. Mark Braunstein. I'm the CEO and founder of the Reconscious Medical Group. Reconscious Medical is a quality system integration platform providing turnkey solutions for psychedelic treatment centers globally. And I'd like to introduce myself today as Dr. Mark with a K. This is a name that a patient recently gave to me. It was quite endearing. I've always been Mark with a K. I got that, but when she referred to me right before a ketamine session as Dr. Mark with a K, it had a whole new meaning, and I loved it. I've been a psychiatrist for about 20 years, and I was trained as an adult psychiatrist and a child and adolescent psychiatrist as well. I moved to Colorado after my training, and I moved there because I could practice medical cannabis in addition to regular psychiatry. Over the past 20 years, I've gone from using psychiatric drugs as first-line treatments instead to using plant-based medicines first and using psychiatric drugs only as a kind of a last-ditch effort to help. I've opened up several medical clinics over the last 20 years. Currently, I'm the medical director for 3 different psychiatric clinics. It also incorporates psychedelic medicine, including medicinal mindfulness in Boulder, Colorado. I'm also on the medical and advisory board for Psyched. I've been consulting in a wilderness setting for over 14 years. And I also own and operate a dispensary and grow in Colorado. And now I'm the CEO and founder of Reconscious Medical, where we are hoping to combine traditional psychiatric treatment with entheogenic psychotherapy. Well, enough about me. Let's get on to ketamine. Ketamine first came out in 1962. It was derived from PCP. You might be familiar with PCP as a very intense drug of abuse. You might have heard of it. This kind of, I think, lends to the negative stigma that ketamine carried for a while. It was originally thought of as a veterinary anesthetic in Belgium. And in '64, we started doing human trials in the US. It was done on a prison population. We studied about 100 different prisoners. And it was interesting. About 1 in 3 of those prisoners had a negative side effect. And that negative side effect was described as a feeling of floating in outer space and having no feelings in their limbs. At that time, the term dissociative anesthetic was coined. And that's how ketamine was categorized. It became commonly used on the battlefield during the Vietnam War because it was so safe. It was called the buddy drug. One soldier could give it to another soldier, and it could be relatively safe, and wouldn't have to worry about cardiovascular or respiratory collapse or crashing on the field. I think this kind of sets some of the tone for how psychiatrists use it so comfortably now. And then not much happened in the ketamine world. It was used as a surgical anesthetic over the next 20 years, but in 1990, that's when kind of like the next big thing in ketamine happened, when its mechanism of action was discovered. It was discovered that the NMDA receptor antagonism was responsible for that dissociative anesthetic effect. So that's kind of a big deal. We kind of understood how it worked. Then around 2000, the first study came out showing its efficacy in the treatment of depression. That was using an IV model, similar to what's being used out in clinics now. In 2000, 2002, 2006, subsequent studies showed its efficacy in depression. That led the groundwork for around 2010 when the first IV clinics started opening up in America. These IV centers would offer ketamine as a biologic treatment for depression with good results. And so around 2010, the first ones opened up, and now we've seen the plethora that are open in the United States now, opening globally, and now we see the combination and the advent of psychedelic psychotherapy clinics beginning as well. I know my own Medicinal Mindfulness, we opened up last year in 2019. And then another big development with ketamine is the development of other ketamine-related products, like S-ketamine. I know that R-ketamine is under study right now. So that about catches us up to the current 2020 of ketamine. And now let's look at how ketamine works, okay? It's somewhat confusing. It's somewhat of a dirty drug. I know I talked about how the NMDA receptor antagonism is responsible for its dissociative effects. Like you heard in the ibogaine lecture, at different doses of ketamine, like ibogaine, you can have different effects. And that's because of the different neurotransmitter profiles that are acted upon at different doses. Such as at really low doses, the euphorogenicity and stimulation because of the dopamine and opioid receptors occurs. Also, the disinhibition, intoxication from the GABAergic effects of ketamine. I think this is why ketamine is really popular at low doses in a recreational setting. In a recreational setting, people are scared of the macro dose because they can put them into what's called the K-hole. The K-hole is very scary on a recreational setting as you're hallucinating and unable to stand or control your motor functions. However, in a therapeutic setting, that higher dose of ketamine, where we act on that NMDA receptor antagonism, is where that healing process begins. So because of that NMDA receptor antagonism, your default mode network is short-circuited. You can think of your default mode network as the electrophysiological biologic representation of your subconscious thought. Your subconscious thought is what drives your neuroses and your defense mechanisms, and often leads to negative patterns of thought and depressive moods or anxious moods or what have you. It's thought by short-circuiting that default mode network, stopping that the negative subconscious patterns of thought, and then creating new patterns of thought via neuronal growth, via dendritic sprouting between the limbic and thalamocortical systems. That new brain growth is actually creating new patterns of consciousness, right? So you get rid of your subconscious, creating new subconscious, new patterns of consciousness, almost like you have a reconscious created. And that's what creates the positive effects of ketamine. So your old past patterns of your subconscious thought, your depressive thoughts, your anxious thoughts, your obsessive compulsive thoughts, where you hold your trauma, you remember your trauma, how you're triggered, that can all be changed through rewiring and creating new, happy, pleasant patterns of thought. It's quite amazing. That's how ketamine works biologically. We're going to talk psychologically later because it's not all about the biologic here. It's really important to remember this is not a silver bullet approach to mental illness. We've been doing that in psychiatry in a long time, and it would be horrible to see that silver bullet approach taken with the psychedelics as well. Ketamine does have dangers and risks. Let's talk about that a bit. You know, ketamine sounds scary because it came from PCP. PCP has a very scary history. You know, a lot of ER visits and medical visits in the 60s and 70s because of this drug. A lot of assaultive, aggressive behavior. But we don't want to confuse ketamine with that, okay? So let's talk about what are the possible negatives of ketamine. Well, one, hallucinating. Hallucinating can be quite scary if proper attention is not given to set and setting. If the proper intention is not there, someone's not educated about it, and they're out in a recreational space, hallucinating is not fun or appropriate, and that can be what leads to someone to have a bad trip. Again, a psychedelic experience can also be psychologically damaging in certain populations. Someone with a strong predisposition towards psychosis or mania, this medication can send them to the moon and have a very negative side effect for them. And also that therapeutic place by using that high dose of ketamine to put people into the K-hole, that's a really scary place for people in a recreational setting. So in a therapeutic setting, the high dose causing this is not a concern. But in a recreational setting, it's quite concerning. People aren't able to control themselves. They can't walk. They might fall over. So again, worrying about falling, that's a serious risk with ketamine. Worrying about someone getting behind the wheel and driving, that's a serious risk of ketamine. And also, it's horrible, but people have used this as a date rape drug. So leaving yourself vulnerable because of the effects of ketamine is also a serious risk of it. I think when people use this medication too often recreationally, it leads to a kind of a chronic dulling of the psyche. This is not what we want. If you want a chronic dulling of the psyche, take lithium or Prozac. So again, ketamine has to be used intentionally and sporadically. If used too much, it can dumb you down instead of raising your awareness. I think its euphorogenicity is also a risk. When taken at low doses, it just makes you feel good. It makes you feel happy. It makes you feel talkative. It gives you energy. And someone can have too much of a good thing. We're starting to see that now in an outpatient setting. People who are usual recreational abusers of cannabis creating dependence. Because it does have effects similar to cocaine and OxyContin. However, not in the doses we give. Let's talk about why we're using ketamine. Because right now in psychiatry, we're kind of in this rush to treatment. Like we do with the SSRIs, the SNRIs, the stimulants, the ADHD medications, the anti-anxiety agents, the mood stabilizers, the antipsychotics. We're at this rush to give ketamine now for every different indication there is. Other than acute mania, schizophrenia, acute psychosis, and acute substance abuse without the interest in getting sober, we're using it. We're using it in depression. We're using it in bipolar depression. We're using it in anxiety, OCD, PTSD, family therapy, couples therapy, addictions, personality disorders, autism, really any psychiatric condition you can think of, we're doing it. We're grasping at a straw. So I'm starting to see the use of ketamine in the mental health setting kind of going to how we're using all other psychiatric drugs as this biologic bullet. And I'm really reticent to see ketamine go down that path because it has so much more to offer than just a biologic treatment. But you are seeing psychiatrists adopt the use of ketamine and put it into place as we use all other psychiatric medications. So besides for all these diagnoses, we're also using it like we do in psychiatry in combinations. So I think you're all unfortunately aware of how psychiatrists love to combine medications, use multiple medications. Well, now they're doing that with ketamine too, because if your Prozac's working a little and your Depakote added on is helping, why not add ketamine too? So again, now we're seeing polypharmacy with ketamine, which is quite unfortunate instead, because ketamine can be wonderful monotherapy, especially when used as psychotherapy. Ketamine can be used as a way of getting off all your other medications instead of just piling on. So we have to be careful with the culture of psychiatry and its polypharmacy, which goes to us using ketamine as psychiatrists in addition to shock therapy or transcranial magnetic stimulation. Psychiatrists in America love the concept of more is better. And I would instead advocate for ketamine in addition to exercise, ketamine in addition to proper diet and nutrition and intention, in combination with meditation, I'm sorry, but lots of ways that we can use ketamine outside of the traditional psychiatric paradigm. So we have to be careful as psychiatrists and physicians to not put ketamine into the same paradigm as all other psychiatric medications, because psychedelic medications are different and special. Let's talk about when you wouldn't want to use ketamine, okay? Ketamine can be dangerous. It can cause heart attack, stroke, because of high blood pressure and increased blood pressure. So that's kind of the main reason is uncontrolled hypertension, we wouldn't want to use ketamine. Uncontrolled hyperthyroidism, because of its ability to cause hypertension, we wouldn't want to use ketamine. Pregnancy, breastfeeding are contraindications. Now, that being said, you can send someone to their physician to get worked up for this and to be made sure, such as if someone does have high blood pressure or hyperthyroidism, that they can be treated. And if someone can be stabilized, then they should be given ketamine. You also want to think about the risks and benefits of treatment. The psychiatrists recommend shock therapy as first-line treatment in pregnancy. But is that really the best treatment? You have to look at the risks and benefits with every treatment given. So I don't want to think about absolute contraindications, but instead think about personalized medicine and how do we assuage the risks and benefits of treatment, decide with the patient what's best for them. We also want to think about substances that might cancel the ketamine as being contraindication. If someone is on too much of a benzodiazepine or too much of an anticonvulsant that won't allow the ketamine to work unless we give too much of it that's dangerous, that's obviously not a great combination. But maybe someone can work with their physician on decreasing the doses of their medication before they come to get ketamine. So again, you can see how this is flexible, and there aren't so many absolutes in this medicine. Active substance abuse is thought by some people to be an absolute contraindication to ketamine, but I disagree, because ketamine can be used in addictions. So if someone is actively abusing substances but wants to get sober, that's a reason to give ketamine. As long as they're not actively intoxicated, right? That's a different thing. But if someone's actively abusing substances and just wants to come use ketamine to get high, that is a contraindication. You also have to think about unrealistic treatment expectations. I think that we have a responsibility to not buy into this and not sell the silver bullet approach, not create dependence and addiction like physicians have done with OxyContin for years. We have to be careful not to create addiction to people coming back to these IV ketamine centers over and over again, and then forcing them out on the streets to get their ketamine. Again, in medicine, we recreate patterns. We're in psychiatry recreating ketamine the way we're using it the way we did with SSRIs, with pain doctors. We have to be careful that we don't go down the road with OxyContin, like OxyContin with ketamine. So we don't want to sell into that. Again, the other thing we have to be careful of is dissociative trauma. If someone has had trauma while under the effects of ketamine, giving them ketamine can be incredibly triggering, and they can have a horrible experience. That being said, like in substance abuse, we can also use ketamine to cure the dissociative trauma. Very interesting. But that's when combined with psychotherapy, not just given the IV model without proper care and set and setting. You know, what's kind of interesting about ketamine is that there are some different ways of using it, right? We've talked a little bit about this with macro dosing, micro dosing, and medium dosing. Let me get a little bit more into that. We can have micro dosing of ketamine, and that's kind of the psycholytic model, where you use a lower dose so that the patient is able to talk during treatment. And this is actually great for psychotherapy. So if someone has a psychotherapy practice and they just kind of want to loosen the patient up a little bit, have them see things in a little bit of a different light, we can use that psycholytic model. And that's going to be variable in frequency of treatment and duration of treatment. It's kind of open to the relationship that they have with their therapist. And this is kind of a smaller rate it's been using. This low dose model over here, the IV model, that's what's being used a lot. The patient has a very mild intoxicant effect and maybe mild hallucinations, but that's not what they're going for. There's no therapy given. It's a biologic treatment. They're given this treatment twice a week for 3 weeks, and they get better. And then they're going to probably come back to you in a year or 6 months because they need to get better again. And that's what I'm concerned about, is fostering addiction. That's not what we're in the business of with ketamine. We're trying to help people with addiction. So it's really scary to me to see these addictions getting fostered. The protocol that I prefer is ketamine-assisted psychotherapy, the CAT model. And that's where we give a macro dose of 1 to 2 milligrams per kilogram. It's interesting though, it's a macro dose, it's a higher dose, but it's not given in a medical setting like the IV model. It's maybe in a therapist's office or at a home visit. And the patient experiences a deep psychedelic experience with visions, hallucinations, perceptual changes. And this whole session takes several hours. And again, but the frequency and duration is going to, again, be similar to that low dose. We find about 6 treatments is the best for transformative change. And that's because these journeys are cumulative. They add on to each other. They grow onto each other. So yeah, you might feel better after 1, but you're going to feel much better after 6. And then you're going to have this therapeutic kernel to take with you and carry forth and practice every day. So at the end of a year after CAP session, you're going to be better than you were after 6 months. And you're not going to be coming back to me asking for more ketamine. Maybe a booster here and there to go back into that place and revisit it and strengthen your resolve, but not the dependence that we see with that low dose IV model. A little bit more of why do I prefer ketamine assisted psychotherapy? And again, if you don't do the psychotherapy, someone's going to feel better. They're going to have a hallucinatory experience, but they're not going to integrate it. They're not going to understand what those hallucinations meant. They're not going to practice this. CAP, that high dose takes you right through your defense mechanisms, past your neuroses. You don't have a choice but to look at those dark places of yourself. That's often those dark places, those shadows. That's what gives people bad trips sometimes. But ketamine has such a gentle, accepting way of showing you your negative places. You're able to see them, think around them, and grow. And when we do ketamine-assisted psychotherapy, a lot of attention is given to set and setting so that the patient feels safe and they're able to journey and they're not afraid of going into that bad place. It's really a wonderful process. Let's look a little bit about what it looks like on a step-by-step basis, okay? Because the first thing is you're gonna get screened. You're gonna get screened that you can even come in, right? To make sure that you don't have any absolute contraindications mentally or physically like we talked about earlier. Then once you come in, you should see the doctor and the physician should come up with a dose for you, which is quite interesting, than a different process of dosing, because they're actually gonna talk to you about what plant medicines you may have taken before, if you've taken any LSD, psilocybin, cannabis, and then they're going to ask you about it in a way that no doctor has before, wondering about how much you've taken, how many hits of LSD, how many grams of psilocybin, and really taking that knowledge. How much did you take compared to the people around you, and what were your effects? Did you have bad effects? Did you have good effects? Then we're going to look at your, how caffeine affects you, how tobacco affects you, how Prozac, how any psychiatric medications affect you. Look at your constitution and really come up with a dose that we think is going to give you that psychedelic effect. Again, that 1 to 2 milligrams, that's per kilogram, that's a range. It's not a one size fits all. I see very large, very experienced travelers that need only a little bit of medicine. And then sometimes really someone who's really hardwired or extremely neurotic that might have never had a journey, they might need a really high dose to take them up there. So we're going to do our best guess to come up with a dose. Patients should be fasting beforehand, again, so that if they get sick and they vomit, there's less to come up. We also don't want them drinking a lot. You don't want them getting up to urinate during this treatment. We're going to have them feel safe, have them feel relaxed, have them feel calm, know everything that's coming up, have them prepared for the hallucinations, have them prepared for visions so it's not scary, have them prepared that they can't move. So people know what's coming. That's going to be key. They have intention set for this. They've thought about what they want to get out of this. It's a very, very thoughtful process. And then the medication is given. This can be given in a clinical way or in a ceremonial way. It's kind of about what the doctor is about. At Reconscious Medical, we prefer a very traditional ceremonial fashion to make this very special. And then the patient's journey begins. You know, it's maybe only 10 minutes after you take the medication that it will have taken effect. And then we're going to give a pre-arranged booster dose added to that to help make sure you get to the right place. Your journey is only going to last about an hour. At the end of that hour, the physician or therapist should be spending time with you, wrapping up what you saw, making sense of those visions, hallucinations, perceptual realizations, packaging them for you in a therapeutic way that you can understand. Either it might be connectedness, it might be give and take, it might be acceptance, it might be a letting go of old patterns, it might be seeing your trauma or your family of origin a different way. Whatever it is, it's that thought and that belief that you want to integrate every day. And that's what makes this powerful, is taking those perceptual beliefs and visions, packaging them up into a way that you can understand them psychologically that will help you. And then remembering that every day, going back into that sacred place in your mind and acting upon those realizations. And that's the psychotherapy. It's kind of similar to cognitive behavioral therapy in some ways, I found. But it's that daily practice that gets you better, because the mind is like a muscle. The more you work it out, the easier those patterns of feeling better will come. How long does it take to work? You know, people often feel better after their first session with us. But again, they build upon each other. 2, you feel better. 3, you feel better. And really 6 is thought to be kind of like the standard of care, that amount. It feels like after 6, you get a bundle of treatments. You have a lot of neuronal regrowth, psychotherapeutic growth, and you feel better. And that message, that integration message is really strengthened after 6. But if you're going to do your work and your integration and your therapy, you're going to keep getting better. Month 2, month 3, month 4, month 6, month 12, they're all going to be increasing. So hopefully if you do ketamine assisted psychotherapy and practice the work, you'll be better at 12 months than you were after 6 weeks. And I think that's different than what we're going to see with the IV model. So again, at the Reconscious Medical Group, we're not into fostering addictions, we're into treating addictions. And by using ketamine-assisted psychotherapy in this way, I think that we're not going to be fostering addictions. Let's think about some future considerations for ketamine in the future. We've talked about all these different indications. I'd love to see some research. Let's get some scientific evidence about the use of ketamine in all these different conditions, so that we're not just using a shotgun willy-nilly approach. We're applying scientific rigor to our treatment models. I'd also like to see, obviously, a higher proportion of ketamine-assisted psychotherapy clinics to IV clinics. Right now, it seems like 99.5% of the work done in the States is in this IV biologic model. I'd love to see a shift more towards the psychotherapy. I'd also like to see investigation of more related compounds, such as an R-ketamine. I think we need to increase research on ketamine-assisted psychotherapy. There's been fantastic work done at the Ketamine Research Foundation with Dr. Phil Wolfson, but he shouldn't have to do this alone. Thank you very much. Again, I'm Dr. Mark Braunstein with Reconscious Medical Group, where we use quality and integrative healing to put our subject matter expertise, technology, and data science to work on mental health problems that stand in the way of people enjoying healthier, happier lives. I'd like to open it up for any questions now.
Thanks so much, Mark. Really appreciate it. Awesome work that y'all are doing and really great insights. One of our audience members says, thank you, Mark, with a K. So let's jump right into a question. Let's see. There were a couple here. I think that you answered this, but just to reiterate again, potential for addiction when ketamine is used in a more therapeutic setting. Is it possible? Could you speak a little bit to it?
Yeah, I think that we always have to worry about addiction and keep aware of it. And I think it can happen in a psychotherapeutic setting as well. However, much less so than in the medical model. Because in the psychotherapeutic setting, you don't quite have the euphorogenicity that you do at those lower doses.
Mm-hmm. And is ketamine a good option for a person with post-acute withdrawal after detoxification from opiates, possibly after detoxification using ibogaine?
I think that ketamine, I'm not going to touch on ibogaine for those purposes because ketamine is my specialty for addictions, and I think it's great in post-acute withdrawal, really to help people continue their resolve and to stay sober, because it can give them a chance to look at their addiction in a whole nother way. It's a whole different paradigm, man, where you're not just having to stay away from the poison, but you're understanding it. You're understanding your dance with the poison, and maybe why now that poison's not the right dance partner.
Mm-hmm. And is it easier to talk about the ketamine experience afterwards than it is a strong LSD or psilocybin experience?
Yeah, one of the things I really like about the ketamine experience, it lasts, when given intramuscularly, it lasts about an hour. And it's not as depleting on the system as, say, a heavy 4-hour psilocybin journey or an intense 8-hour LSD journey, where oftentimes after those, people are pretty physically and mentally wiped out. Their mind has been traveling and exercising hard, man, for hours. Whereas ketamine, after an hour, I find that people are refreshed and ready to get in there and process. It's great.
Definitely, definitely. Well, Mark, beautiful. Learned so much. Thank you for coming on. Thank you for sharing your insights and answering questions. We really appreciate it.
Thank you, Merrick. Blessings.
Yeah. Peace, man. Be well.